Importance of this space. Liver abscess for the pus formation in the liver can burst and it can penetrate through the diaphragmatic peritoneum and it will reach the right pleural cavity. So abscess from the hepatic or the liver can go into the pleural cavity and it may cause the dyspnea or difficulty in the respiration. Then if I put my hand above the left lobe of the liver, if I put my hand like this, I cannot go on right side. Why? Because my hand is arrested by the left fold of the falciparum. And my hand is in the left subphrenic space. So this is the left subphrenic space. Here also the lung abscess, the hepatic abscess can go into the. So that is the two right and left subhepatic. Then right and left subhepatic space. Sub means below, hepatic means the liver. So when I put my hand here, that is below the right lobe of the liver. My hand is in the right subhepatic space. And this right hepatic space is very critically important and it is also called Morisons pouch. Right subhepatic space is also called, other name is called the Morisons pouch. We go into detail. First we enumerate all of them, then we take one by one the clinically important spaces. So this is the Morisons pouch, or the other name is, third name is hepatorenal pouch. Hepatorenal pouch. In exam, the question may be asked either of the name. Then, when I put my hand here, below the left lobe of the liver, what is here? Lesser omentum. Then, stomach. I cannot put my hand here. In order to go below the left lobe of the liver, I have to go through the foramen of Winslow. And when I put my finger in the foramen of Winslow, I reach the lesser sac. So other name of the left subhepatic space is lesser sac. So both right and left subhepatic spaces, they are important. Morisons pouch as well as the lesser sac. Then comes the duodenum. So duodenum, as we know, whole of the duodenum, first part, second part and third part, they are all retroperitoneal. But the last fourth part, which is continuous with the jejunum, is the slightly movable. And from right side, when I put my finger, I can lift the fourth part. So this is called the retroduodenal space. Retroduodenal space is also the perineal pouch. Right as well as from left side also, there is a duodenal space here, right and left. So they are called the right and left retroduodenal spaces. So that is the duodenum is only related, fourth part only is related to this. Then the subhepatic spaces on the left side, extreme left side is the spleen. And from this splenic flexure, a fold of the peritoneum of the transverse mesocolon goes to the diaphragmatic peritoneum. A shelf-like projection of the peritoneum from the splenic flexure or the right end of the transverse mesocolon goes towards just below the lower pole of the spleen and attached to the diaphragmatic peritoneum. This fold of the peritoneum is called the phrenicocholic ligament. Phrenicocholic. Phrenic means diaphragm. Phrenicocholic ligament. So this ligament prevents the gravitational slipping of the spleen while we are jumping. So when we jump, there are chances that spleen may enter here. So this shelf-like projection will give the resistance to the descent of the spleen is prevented. So that is the function of the phrenicocholic ligament. So these are all are the supracolic spaces. Now come the infracolic spaces. So infracolic spaces, they are broadly two. This is the one space below this colic transverse colon. This is the right infracolic space. It is triangular. See, this is right, and this is the left. It is also triangular. So there are the right and left infracolic spaces. So right infracolic space, the boundaries they are formed by. So apex is towards the cecum. Base is formed by the transverse column, mesocolumn, and on the right side is the lateral abdominal wall, and on left side is the root of the mesentery. So this is how a triangular space is formed on the right side of the mesentery, called the right infracolic space. Similarly, the left infracolic space is also formed, but it is opposite. Its apex is upward towards the splenic flexure, and base is towards the pelvic cavity. So this is the right and left infracolic spaces. Now this is the space again where the ascending colon lies. This space is called the right paracolic gutter. Right paracolic gutter, here lies the ascending colon. And similarly on left side will be the left paracolic gutter, where lies the descending colon. Descending colon will be here. So these are the infracolic spaces. And below the pelvis there come the pelvic spaces. Pelvic spaces, they are separate. And we will deal when we do the pelvis in the last part of the abdomen. Now we are only doing the major part. So now we will take clinically important space, that is the Morisons pouch. Now Morisons pouch is also called the hepatorenal pouch. Why? Because it lies below the inferior surface of the liver and the right kidney. As you know, this is the duodenum. The duodenum, the lateral border of the duodenum is related to the right kidney here. So right kidney lies retroperitoneally here. The hilum of the kidney is overlapped by the duodenum, and above this lies the suprarenal gland also. Rather, liver overlaps a little bit of the upper pole and the suprarenal gland, so there is an impression on the inferior surface of the liver of the suprarenal, right suprarenal as well as the right pole of the upper pole of the kidney. So if I put my hand here, my hand is in the Morisons pouch. How you write down about this? Boundaries. Anterior, posterior, lateral, medial, superior, and inferior. So this much heading you have to make while explaining the Morisons pouch. The anterior boundary is formed by the anterior abdominal wall. Anterior most boundary is formed by the anterior abdominal wall. Posterior. When I put my hand will touch the right kidney and right suprarenal gland and posterior abdominal wall. What is posteriorly? Right kidney, the suprarenal gland, and posterior abdominal wall. With all its structures, there is the pars major and the quadratus lumborum also. So this is the what is, and what is the clinical importance of this Morisons pouch? Because this is the deepest space while patient is lying on the bed. Deepest means I am going from anterior abdominal wall to the kidney, and where the kidney lies? Posteriorly. It means from anterior to. So this is the most dependent part of the abdominal cavity in this supine position. So that is its clinical importance also related to this deepest position. Then come on the left side. On the left side, this suprarenal pouch, this Morisons pouch will go through foramen Winslow. It is communicated to the lesser sac. So on left side, it is communicated to the lesser sac through foramen of Winslow. Then on the right side, so in the abdomen we are using right and left. There are more appropriate terms rather than lateral and medial. So there is the left extension of this space. Now left side. When I go left side, now left side it is communicated with the right subphrenic space. Right subphrenic space. Plus, on right side is also communicated with the right paracolic gutter also. Right paracolic gutter is also expected to be inferior relation. So how it is going downward when we go. Then inferior. So on the right side and on the inferior relation. So inferior is related to the upper layer of the transverse mesocolon. Upper layer of transverse mesocolon. So this is how the three-dimensional picture should be in your mind while you are doing the Morisons pouch. So these are the boundaries. Now come the clinical importance. Clinical importance is because of the so many things are related to it. Number one is the post-operative morbidity. Post-operative morbidity is the first and very important clinical significance. Post-operative morbidity. What is morbidity? Morbid means not well. Not well is called morbid. Sir, I am today morbid. Means something. This is medical term, not general use in the general people. In the medical term, we use this so many times. So morbidity means something is sick or not well, not medically fit. So we say the morbid state. And this is post-operative. So whenever we do the operations of any organ in the abdominal cavity and we close it, we expect that there is a oozing of the serum from the operated side will be there. Some reactions will be there, some infection may be there, or just the normal response to the human body will be there. So fluid collection will be there. Something coming out of the operated area or the stitches you can say. And this material or the liquid is very prone to the infection focus. So we try, that's why post-operatively and pre-operatively also we give a good amount of the very good prophylactic antibiotics to the patient before we doing the operation. And also post-operatively also we give the good quality of the antibiotics so that we can contain the infection of that particular area. Even then, some of the infection is there. So many factors are there for the infection. So whenever there is a oozing of the serum or infected material from the operated side, because this and patient is lying in the bed, because it is operated, pain is there, you can't walk and stand or sit. So patient is lying in the bed in the post-operative position, and from the oozing of from any organ, for example, we have done the appendicitis, we have done the cholecystitis, we have done the gastric, or any operation we have done, whole of the serum because of the dependent position will be collected in the Morisons pouch. Because this is the lowest in whole of the abdominal cavity. And this forms the infected focus. And we try to remove this amount of the fluid from here. Otherwise the patient will, the stay in the hospital will be prolonged. So this is the reason during the first day of the operation, patient is having very painful. That night is very troublesome because that night is having the many pain. We have to give the injections and so many things to the patient to relieve the post-operative pain. But next morning, when doctor is coming to inspect the patient, how is he or she, we expect that she or he should sit in the bed at the angle of 45 degrees. The patient should sit before the doctor comes for 11 o'clock or 12 o'clock in this position, that is the 45-degree angle. Why we promote this? Because we want the Morisons pouch, the fluid which is collected overnight, should gravitate down and should come in the pelvis. Pelvic peritoneum is having very large surface area. and it acts as a semi-permeable membrane, and we are using for its dialysis, you know. So we want the Morisons pouch should be empty with this 45 position, and whole of the pelvis is filled with the fluid which is reabsorbed and becoming disease free. But some patients are so fussy, they are having, oh no, so they won't sit. As they won't sit, their stay in the hospital will be long, because the focus will be in the Morison's pouch. If she or he is not coming in the 45-degree angle as early as possible, patients who are coming and sitting in 45 degree as early as possible, they are good for the surgeon and the doctor. Who are fussy, we are very worried about these people, because they are giving deep into the doctors and the all of the crew. So this is called the early ambulation. Ambulation means movement of Morison's pouch fluid come. So in the van, what is like an ambulance? What is the meaning of ambulance? Patient from home to the hospital, from hospital to the home. That is the ambulation. So we are using what is the ambulance in the word this way. Ambulation, movement of the patient, sick. Then on the same day, surgeon expects that when he comes to the evening round to see the patient, the well-being of the patient, he or she should walk in the room a little bit after taking precautions, putting hand on the operated area. He or she should slowly walk, because we want the patient to stand, become vertical, so that whole of the Morrison pouch will be cleared, should be emptied, and everything should come on the pelvic cavity. That is the motive behind the early ambulation. So that is the clinical importance. If patient is fussy, is not sitting on 45-degree angle within 24 hours, not walking in the room, so infection will be there. The stasis of these infected fluid will invite the bacteria to grow them. Because for the bacteria, there is the feast, the serum and everything which is oozing out of the operated area. So they will grow, and patient becomes more and more sicker. And how the importance of how we expect the patient is going sick, that is the temperature. If post-operative patient temperature is not going, if it is increasing, it means patient is having infection. So that is the simple way how to tackle the post-operative morbidity. Second clinical importance is the appendicitis, acute appendicitis. So we know appendix lies in the right iliac fossa or right inguinal region. It's a very painful condition. You may expect anytime during travel in the bus or in the train or in the aeroplane or going in the mall, standing in the mall. Anytime it can happen. So there are so many reasons for the appendicitis, and only one treatment that the patient has to be put on the operation table. He or she should reach as early as possible on the operation table. That is the answer. Otherwise, it may burst and lead to the generalized peritonitis, which is a life-threatening condition. Patient may die. So that is the clinical emergency. That is the appendicectomy has to be done. But some patients are very fussy. They don't go to the doctor. They are lying in the bed. They are lying at home. No, I know. And lying in the bed for so many, taking painkillers, this and that, prolonging the stay in the home, not going into the hospital, not consulting any doctor. What will happen? The oozing and the pus which is formed here will ultimately go into the, because patient is lying down. He can't stand, he can't walk because appendicitis is there. And this whole of the pus will go into the, ascend in the right parabolic gutters. From here, it is reaching the Morisons, because it is the most dependent part, so it will be collected every day, slow and slow. When whole of the Morison pouch is filled, now it will enter into the foramen medulla and start collecting in the lesser sac. Because lesser sac is higher, Morison pouch is lower. As you are done in the cranial cavity, anterior cranial fossa is higher, middle cranial fossa is lower, and posterior cranial fossa is lower. The posterior cranial fossa is like the Morisons pouch, and anterior cranial fossa is like the lesser sac. So when whole of the Morisons pouch is filled, the whole of the pus now start going into the foramen lobe to the lesser sac. So it takes about 7 to 10 days. Now patient will have the pain and discomfort in the epigastrium, because lesser sac lies in the behind the stomach. And what lies in the epigastrium? The stomach. So behind the stomach is the lesser sac. And now he will say, I will go to the doctor. And when he is doctor, we go for the first of all blood test. And he is having septicemia, bacteremia. His total leukocyte count is above 25,000. He is unfit for operation. He may die. So that is the clinical importance of Morisons pouch as well as lesser sac. So whenever you apply lesser sac, then you can write them the same thing. So this is it. Another thing is the acute pancreatitis. So in acute pancreatitis, so pancreas is lying retroperitoneally, and it produces all type of the enzymes: proteolytic, lipolytic, carbohydrate. So the appendicitis means appendix is red, hot, painful and swollen. So that pancreatic juice which was made to liquefy the chyme, converting the paste chyme into the liquid food, is now oozing out of its surface. And that pancreatic, lipolytic and all enzymes, they are acting on the human body itself. They are acting on the mesentery. They are acting on the walls of the aorta. They are acting on the walls of the all structures, the peritoneum, the viscera. They are all made up of protein. So there will be multiple perforations, holes in the viscera, holes in the inferior vena cava, holes in the aorta, and there will be fountains of the blood everywhere. And whole of the abdomen is filled with the blood. That is called the condition that is called acute pancreatitis. And because of the lower position, so Morisons pouch is filled first of all. And this again lead to the peritonitis. The signs of that is also a life-threatening condition. Patient may die because of the signs and symptoms of the peritonitis. So that is how you have to write upon the upright anatomy related to the Morisons pouch. Now comes the lesser sac. So lesser sac is a cavity because of the infolding of the peritoneum behind the liver, behind the lesser omentum and behind the stomach. That is the definition of what is lesser sac, or other name is left subhepatic. Lesser sac or left subhepatic space. And again the boundaries, if you see the boundaries of the lesser sac, they are anteriorly. What are the anterior boundaries? So for the lesser sac you have to make this diagram. Anterior boundary of this lesser sac, anteriorly found by posterior surface of the liver, number 1. Number 2, lesser omentum. Number 3, posterior surface of the stomach. This is the anterior boundary. The posterior boundary, this diagram will tell you. Posterior boundary is found by the posterior abdominal wall, containing left suprarenal gland and left kidney, and also the upper part of the body of the pancreas. See, whatever coming here, they are from the posterior boundary. Or actually the posterior wall is found by the stomach bed. It is also called stomach bed, because all these structures, they are present behind the stomach. Our stomach is lying on the bed. Bed is formed by these structures which are retroperitoneal. Then on the left side, this boundary of the lesser sac, so you have to make this diagram. only upper half. If the lesser side comes, this is the full diagram you have to make, this is the upper half you can make. On left side, the boundary of this lesser side is formed by number 1, gastrosplenic ligament. Gastrosplenic ligament. Then inferior boundary. Who is forming the inferior boundary? Number 2 and number 3 layers, which are fused. So this form the inferior boundary of this lesser side. Then right side. Now right side is open to the Morisons pouch or the Praetorian pouch by an arrow that is called foramen of Brinstow or called epiploic foramen. It's called the epiploic foramen. So from the greater sac I can go into lesser sac. So this arrow is showing the. So you have to make the arrow also whenever you do the lesser sac. So this arrow represents foramen of Brinstow. So you have to explain what is foramen of Brinstow. Just naming is not giving you the numbers. So if this is the lesser sac and this is the lesser omentum, this is the right free border, this is left attached border of the lesser omentum, stretching between porta hepatis of the liver to the lesser curvature of the stomach. And this is the foramen of Brinstow above the pylorus. And only my tip of my little finger goes, because this diameter is only 1.25 centimeter. Write down 1.2 centimeter broad, and it is slit like aperture. Slit. It's not a hole like we have done in the superficial inguinal ring and the deep ring. No. It is a slit like aperture, or it is merged with the posterior abdominal wall. It is very near to the posterior abdominal wall, because it is a continuation of the pylorus, and pylorus is continued with the duodenum, which is retroperitoneum. So if I put my little finger into this epiploic foramen, the lower border of my finger is touching, that is called the inferior boundary. It is formed by pylorus. Upper border of my finger is touching the, what did it touch? Liver. But which part of the liver? C for caudate lobe. Caudate lobe of the liver, inferior boundary, pylorus. You can make the diagram also. And the nail of my finger is touching IVC, inferior vena cava. Inferior vena cava. The nail of my finger. Then this ball of my finger. Ball of my finger is touching right free border of the lesser omentum. You have to write right free border of lesser omentum. So this is the foramen of Brinstow. Right free border of the lesser omentum, and this right free border of the lesser omentum contains portal triad. Portal triad. Because lesser omentum is double layered, and in these two layers there are like three structures that are called the portal triad. And portal triad is formed by number 1, a vein, a artery, and a duct. The vein is called portal vein. The artery is called the hepatic artery proper. Hepatic artery proper in the bracket. Proper hepatic artery. And duct is CBD. Common bile duct. Common bile duct. So these are the three structures. They are present in the right free border. So if I hold the between thumb and finger, so I can feel these three structures in the right free border of the rest. And these three structures, they are having the mutual relation also. That is very important. Who will write down get the more than 80% marks. Mutual relation of these three structures. Now, the hepatic artery proper lies on the left side. Common bile duct lies on the right side. and portal vein lies posterior to the both. So that is the relation. Portal vein is behind the hepatic artery on the right side and common bile duct on the right side, and hepatic artery on the left. So that is the position of the three structures together. They are called the portal triad. So when you trace them, because where they are going up, porta hepatis, that is the hilum of liver. And when we go there, we can trace this into the liver also. They will remain together, even in the liver also. So in the histology, you will do this slide that will be clear that what is portal triad and how it surrounds the portal lobules of the liver. So that is the foramen of veins. And on the left side, if I go in the left side, so that is here, and on the right side, where it goes, open into the Morisons pouch through the foramen of veins. That is the extension. Right, left, anterior, posterior, superior. Now superior, when we see, it goes up. So this small extension of the lesser sac in the upper part is called the superior recess. This is the recess. Now superior recess. And a little bit inferior, this is also called the inferior recess. Recess word we have taken from your lower classes. When you were in the 4th, 5th, 6th standard, in the school there were recess. How many minutes? It should be hours. No. Recess means small interval of the time. And we are not big people, we have picked this word recess, where there is a small space anywhere, smallest space. We use the word recess. As you have done the third ventricle in the brain, there was pineal recess, suprapineal recess. In the floor of third ventricle, there was optic recess, pituitary recess. Pituitary is hanging from stalk of the infundibulum. Two stalk. What you expect the space between them? Very minute. Still we recognize it. It is significant for anatomy. It is called hypophyseal recess. Or then optic chiasma. Two optic nerves, they are meeting to crossing. How much do you expect the space will be there? Very little. Still we say this is the optic recess. So this is the recesses of the lesser sac. That is the extension of the cavity. So this is how you do the boundaries of the lesser sac. The two diagrams, you have to practice too much, I think so, for these two diagrams are very complicated. So go for 20 times, 40 times, 50 times, it should be fingertip, because whole of the abdomen depend upon these two diagrams. And both these questions they have to come directly or indirectly. So be prepared for it. Now come the applied anatomy of the lesser sac. Same as we have done, that the Morisons pouch is related to lesser sac, to foramen meniscus. The same thing can write down. Same appendicitis, first it will fill the Morisons pouch, then it will go into lesser sac. And patient will be present with the epigastric needs. Then same pancreatitis, the pancreas is lying just behind the lesser sac. And oozing is here. So first the infected material will be collected in the lesser sac. The perforations of the stomach and the inferior vena cava and the contents will be here. And whole of the lesser sac will be filled with the blood. So when whole of the is filled with the blood, because pancreas is here, so oozing of the pancreatic juice will come like this. Because it is related to the posterior wall. And when whole of the blood is here, then this blood will trickle down and now it is entering into the abdominal cavity. Go into pelvis. Anyway, patient is lying in the bed. So whole of the abdomen will be filled with the blood. This is called the hemoperitoneum. He means blood, peritoneum means fluid. But before blood goes, appendicitis, this pancreatitis will do the pancreatic juice will attack the walls of the peritoneum. It will eat up. It eat up the walls of the stomach. Holes will be there. Whole of the food we have taken comes here. HCl from the stomach can come. It will do more havoc. Already pancreatic juice is enough. Trypsin and chymotrypsin is quite strong. If you put in one drop of the trypsin in competition, there will be a hole in your skin. It is so strong because you have to convert your non-veg food, hard food, the bones, even the fish and everything into paste. It has to be so strong. Otherwise, bones remains undigested. So that is the problem. So this will eat up the peritoneum, and peritoneum will be damaged, and it lead to the peritonitis. When it is in the lesser site, it is called the localized peritonitis. But if it has come and start entering into the greater sac, the whole of the abdomen will be, peritoneum is everywhere. And every part of the peritoneum will be attacked by the bacteria, and that lead to the generalized peritonitis. Now, the bacteria, they are attacking the whole of the peritoneum, mesentery, transverse mesocolon, greater omentum, lesser sac, Morisons capsule, liver, everywhere there is a pus and bacteria. And that will irritate the peritoneum, and irritation of the peritoneum cause peritonitis. Means peritoneum is red, hot, painful, and so what are the signs and symptoms of the peritonitis? Number one, distension of the abdomen. The patient having the abdomen is like this, because it is filled with the blood and pus and bacteria. So that is the distension is because of the ascites. Second is the ascites. Ascites means fluid in the peritoneal cavity. We have seen peritoneal cavity is empty. Fluid is because of the reactionary fluid. It is called the transudate. If it is infected, it is called the exudate. Exudate is filled with the pus and the bacteria. So there will be fluid in the ascites. Ascites is what we use, fluid in the peritoneal cavity. That causes the pain in the abdomen. Whole of the abdomen is painful. Third sign, silent abdomen. Silent abdomen. Patient is lying in the bed. If you put the stethoscope on the abdomen, people may say that stethoscope has to be put on the heart. Why you are putting on the abdomen? But no, it has to be put on the abdomen. What we are expecting? Normal peristaltic sounds of the intestine. You might have heard sometime when we are lying quiet in the room. So they are called the borborygmy rhythm. Borborygmy rhythm. It comes automatically after a span of some interval of the time. These are the normal peristaltic movements and the sound heard we normally, but it is absent. Because all the intestines wall, they are made up of smooth muscles. Outer longitudinal, inner, and they are surrounded by bacteria and their toxins. So all the muscles, the longitudinal and the smooth, they undergo, when muscles they are irritated, they undergo spasm. So all the muscles they have undergo spasm, the intestine becomes a pipeline. Contracted. No food is going anywhere. Spaces. And patient may show the signs of intestinal obstruction. So intestine is lead pipe-like, hard to feel because of the spasm of the outer and inner longitudinal and circular muscles. And that is called silent abdomen. This is also called paralytic ileus. Paralytic ileus. That whole of the 6 meter long jejunum is silent. And muscles undergo spasm or paralysis. That is the paralytic ileus in the case. Then board-like rigidity. Fifth sign is the board-like rigidity. Board-like rigidity. The patient is lying on the bed. If you normally when we touch the abdomen of the patient, it is soft because there is no deflation. But start touching the patient who is having the peritonitis. The anterior abdominal wall will be like this. Board-like, fly board-like hard. What is this called condition? Board-like rigidity. Why this board-like rigidity? It is because of the irritation of the peritoneum. So parietal peritoneum is also irritated, and you know parietal peritoneum is lying behind the anterior abdominal wall. What is present between the skin and the peritoneum? Number one, from inside, extra peritoneal fat, very thin and filmy layer. Then, facial duct, very thin and fragile. Then, it means peritoneum peritonitis, which is inflamed, is touching the transverse abdominis muscle, which is also in touch with the internal oblique and external oblique. So because of the irritation, all the three muscles will be irritated. And how they show? They undergo spasm. So that is the cause of board-like rigidity. Or rectus abdominis pyramids, all muscles will be irritated and they undergo spasm. That is the cause of board-like rigidity. This is not given in your red book. So see my YouTube lectures and make the everything. You have not written 250 students. I have not only 5 students written their roll numbers. Today, all the 3 lectures of the abdomen I have done here, peritoneum. You should name each and every student, otherwise you will get 10 days absent from the last. I want every roll number, no roll number, only name. No need of roll number. Only I expect the name today with all my 3 lectures of peritoneum. That will give you that impression that you have seen it. Because these things they are not given and they are expected each and every question in the practical as well as the viva. So that is how we do the. So this is a life-threatening condition. Patient may die. Ultimately death. When all is silent, patient is not taking food, he will die. The last is the applied in the perforation of the posterior wall of the stomach. Perforation of the posterior wall of the stomach because of the perforation of the gastric ulcer is very common in the nowadays because of the fast food intake. Early stage, early age people are coming, youngsters are coming with the complication of the perforation of the gastric ulcer. When it is in the anterior wall, the gastric content as well as the HCl will be leaked in the greater sac and patient will die soon because of the generalized peritonitis. If he or she is lucky, if the perforation in the posterior wall, at least the peritonitis is there, but it is confined or limited to only lesser sac. A smaller extent of the peritoneum is irritated and it doesn't cause all the signs, these 5 signs of the generalized peritonitis is escaped. But still, the localized peritonitis may lead to the general peritonitis. So, in the perforation, what happens? All things is leak. Then, how to tackle? We do the laparotomy. We have to operate and we have to close this hole, and patient can be saved if it comes early. So, when it is leaked here, so air also leaked from the stomach, and air is lighter. So, patient comes with the pain in the right shoulder. Referred pain in the right shoulder. Why? Because when the stomach is leaked from the posterior wall, the air will be leaked and it will come into the right subphrenic space. Write down in this second. First we have done the hepatic abscess. Second applied is this perforation of the aneurysm. The air is lighter. It will leak from the stomach, or it may be the gastric ulcer. It may be duodenal ulcer. It may be amoebic ulcer. It may be the iliac ulcer. It may be the colic ulcer. So from any perforation of any part of the gut, air will be leaked because air goes with the food we take. So this air will be leaked, and because of the air is lighter, abdominal cavity is closed. So where air will arrest between the diaphragm and the superior surface of the liver. That is the right and left subphrenic. And this is it irritates the diaphragm. And what is the nerve supply of the diaphragm? Phrenic. And what is the root value? And what is the skin supply of the shoulder? We have done upper limb. C4. So patient with the referred pain on the right shoulder. So whenever the patient comes with the patient right shoulder, if it is right shoulder, it is because of heart. But right is because of the air under the diaphragm. Because the air under diaphragm. So whenever you take the standing X-ray of the patient, plain X-ray standing view, we see the right air here, black color. Normally, no black, this is white. Under the left dome of the diaphragm, the air is normal, this is black color. Why is black color? Because this is the air in the fundus of the stomach. This is normal finding. But air under the right dome of phrenic is diagnostic of the perforation of any hollow viscera. So that is diagnostic of perforation. So this is how we do the. So we have to close it. Where we go, the surgeon will operate, and we lift the peritoneum upward and throw it up, and we break 3 and 4 layers because they are bloodless. No bleeding will be there. So we cut the 3rd and 4th layer, and our hand is touching the posterior wall, and we just give the 2 stitches, close the abdomen, patient. So that is how we go to the posterior wall of the stomach, can be reached from embryonic plane by cutting it safely because there is no bleeding. So that is how we do the operation on the perforation. That's all about the hemorrhoid of the. That's